1981. I've got some of the icons up there. That was Madonna. President Reagan was the president. But it was a great time to be in public health. When I look back, I didn't realize how great a time it was because our director was one of the heroes of public health, which is Bill Fagey. And our Surgeon General was C. Everett Koop. And both of those people, for those of us in public health, were really wonderful heroes for us and inspirational. Now you can look at the class there. We had 41 men and 22 women, and I see Joanne here told me what's in her class, our EIS officer, Joanne Watson, in the audience. She said, now we have 59 women and 25 men in her class. So it's actually flipped around. So public health has become quite a female-oriented profession. I was assigned to the hospital infections program, did a lot of outbreak investigations, very little large data set analysis because our outbreaks were usually probably 10 or fewer people. I didn't have an MPH. At the time, we only about half of the physicians who entered the EIS program had a master's in an MPH or a Master's of Science. So most of us were learning what we learned on the job. We didn't have any PCs. We had a mainframe computer that was, you had to sign up for time on this, and so all the EIS officers, actually it was a bonding experience. We would be in the basement of Building 1 at CDC, all clustered together and trying to get time on the mainframe because during the day most of the staff were on that mainframe and we couldn't get on. We had handheld calculators to do 2x2 tables that took about 2 hours to calculate one Fisher's exact test. So you guys out there, young people, you know, you have to realize how much progress has been made in making our jobs easier. It was also the beginning of the AIDS epidemic, and for our class, Jim Curran at one point, he is quite a, I don't know if you're familiar with Jim, but he's one of the leaders in HIV that has worked both at CDC and Emory University. He's the dean of the School of Public Health there now. One time did a presentation at CDC and listed all the EIS officers in my class and the class after me that worked on HIV. And it was probably 2/3 of the class. Because what happens when we have something at CDC like that, the EIS officers have to all respond. So I think, Joanne, yours has been Hurricane Sandy, right? Sometimes it's bioterrorism, but often these events really define our careers. And this was career defining for me. I didn't realize it, of course, at the time, but the last 15 years of my career at CDC has been working on the HIV epidemic. And it's been a great teacher in public health for me. It's really taught me a lot of lessons about cultural sensitivity, data security issues, way ahead of the time when a lot of the other programs were talking about some of these issues because HIV got a lot of funding at CDC. And we had a lot of very large programs built around this disease. Another interesting difference between now and back then was that CDC was a small organization. I mean, Clifton Road is a little building. I don't know if Dr. Sun will remember that. So, yeah, there's a little building there, and it was a very intimate organization. And I kind of missed that because we kind of all knew everybody. And, Bill Fagey actually participated in our EIS skit. And we had Alexander Langmuir, who's the founder of EIS, actually come to our EIS conferences. He was still, I think, one of the last 2 or 3 that he attended was my class EIS conference, and he would actually ask questions and was quite stimulating. And another thing that happened during that period was this Commission for Reduction in Force. Now Bob Rolfs, who I think most of you know, who's my predecessor at the health department here, says to me, well, you know, at CDC, no matter what happens budget-wise, you never lay anybody off. And I think that's probably right. But back here, we did actually have people being laid off, and this is very discouraging for us as new EIS officers because it really didn't look like we were going to have jobs after we finished. And I think this is a lesson for now because sequestration is putting a lot of pressure on us as public health people. And one of the things that this taught me very early on in my career is you need to be flexible if you want to be in applied epidemiology. And I actually, when I came out of EIS, I took a position, like they listed the positions that were available for EIS officer graduates, and I took diabetes. So what I could get. But actually, that was fortuitous because, you know, all that large data set analysis and SAS stuff that I never could do in hospital infections, I was able to do there. So I learned quite a bit of that on the job there. And then I also think I got interested in some early cost-effectiveness analyses because my supervisor there was Stephen Toich, who was eventually that became his prevention effectiveness was his second career. And then this last thing I've written on there, there was a guy named Lyle Conrad who was the chief of the Division of Field Services, and that's where all the EIS officers went who were going out to state health departments, and he supervised or oversaw that program. And he told my husband and I, you know, early on, I just remember when we were looking for positions, well, you're either a field person or a headquarters person, and never the twain shall meet. And for me, this is a little bit discouraging. I was pretty neutral when I came into CDC because I had come in so early in my career. I hadn't really differentiated very much. And so I, you know, kind of liked both. But he seemed to indicate that probably we couldn't do both. But I think in reality, and in more recent years, this idea has gone away. And I think that I'm hoping that we can learn from each other as I am the state epidemiologist, that I can bring a federal perspective to things, but that I can also learn the state perspective.
Were you in the commission court?
I was.
Because when you talk about flexibility, I'll share quickly with you, seeing Dr. Coop up there. When I was responsible for his confirmation hearing in the Senate, which was a very long, protracted 8-month thing. And we were under the gun for a lot of reasons, not least with this OMB. We didn't like the commission corps, thought that they were lazy, they did not deserve the benefits of the military because they didn't behave that way. So when he came, he decided we would go uniform, and he went uniform, of course, and made everybody behave more like if they're going to have the benefits of the military, they're going to have to behave like that, meaning be mobile, be flexible, be able to be deployed. And so I don't know if you've noticed that then, but he really started early on making sure if you were going to have a uniform service in public health, you'd have to behave like a little more disciplined, and it couldn't just be headquarters for field. You had to be able to be at the ready. So he really brought some integrity back into the commission corps and saved it because OMB backed off wanting to terminate.
Right. And I think that's right. When I look back, I didn't like that change, I can tell you, because I spent my early years in STDs and then later in HIV, and in those areas, wearing a uniform really didn't help you very much. In fact, it was kind of a hindrance to getting your work done. But when you look at the overall commission corps, I agree with you that idea. Now the thing that I think was lost is that all of us in the commission corps, I think people who go into public health really have that desire to be helpful, and if there was ever any emergency or anything that needed to get done, I don't think there was ever a question that we would respond to that. But I think it was this idea of being much more of a uniformed, sort of a disciplined military type service. And so I went through that because I didn't, you know, I spent 30 years in the commission corps, and so I don't think it was until the last, I think 10 years before I finished is when I took basic training because they finally required everybody to do it. Okay, let's get this. All right, so good bureaucrat. I'm going to start with, as I tell you about our role now as the state epidemiologist here, an org chart. One of the things that I did when I went back to the CSTE orientation for new state epidemiologists was go around and ask or poll the other new state epidemiologists there where they were located in their health department organizationally, and then how did that affect their function. And so I've written this adage at the bottom that's a quote from Menkins et al. If you've seen one public health, or one health department, you've seen one health department. It was remarkable how unstandardized this position is. That's why this talk is a little bit difficult, because the state epidemiology position in different health departments is vastly different. In one of the health departments, it's actually located off to the side, but above the division director, where Teresa is located, up in the office of the director of the health department. But it's completely consultative position. There's no managerial responsibility at all. Another health department had a situation where they had an infectious disease fellow who was going to be over communicable diseases and lab, but nothing else. Another health department, this was for Virgin Islands, is one laboratorian who was barely keeping his, I think they were still doing everything on paper as far as surveillance, and that was the state epidemiologist from the Virgin Islands. So it's a remarkably un-uniform job. One of the health departments of South Carolina, my good friend Jerry Gibson was the state epidemiologist there, and he was like Bob Ross, can do everything kind of a guy. So he had the position of the deputy director of the health department as well as the state epi position. But when he left to do something like what I was doing, which is go overseas to Africa, they couldn't recruit his replacement. And so they had to split the job back out into two positions because people said that they just couldn't do both jobs, and it was just not a practical job. So, and that may have been what happened here. Maybe Teresa or someone can tell us more about how they decided to locate this position. But so the position that I'm in is located under the Division of Disease Control and Prevention, with Teresa as the head, and then Jennifer Brown as the Bureau Director of Epidemiology, where the position is located. And then I actually have direct managerial responsibility over 3 teams or programs which are responsible primarily for communicable disease surveillance. So that's communicable disease analysis and reporting, communicable disease investigation and response, and most recently hospital or healthcare associated infections, because that's become a more of a prominent topic. Well, so since polling the epidemiologists that were at that orientation didn't help me much, I started looking at some of the literature that they passed out at this orientation. I think 2 things were very helpful to me at the bottom there. Public health reports on applied epidemiology competencies. I think probably the and then a CSTE National Assessment of Epidemiologic Capacity. This was actually done in 2009. I don't know what they were doing to make the publication so late, but it won't come out until this June. But in those documents, these are the definitions for applied epidemiologist, applied epidemiologist, and state epidemiologist. And basically, The state epidemiologist that you see last there is the liaison with CDC for matters related to disease surveillance, investigation, and control, and the state's official representative to the Council of State and Territorial Epidemiologists. And that's basically all that's said about what those positions are like. CSTE, for anyone who's not familiar with this organization, is the professional organization for applied epidemiologists or field epidemiologists. It supports public health policy and epidemiologic capacity in our health departments and promotes effective relationships among states and other public health agencies. And I think the last provides technical advice to its partners, especially CDC. And, you know, when I look at the federal perspective, we, you know, the feds often are responsible for developing guidelines or policies and funding, and we really need input from the states to really tell us what we should be doing, because you know, we're ivory tower in some respects. I mean, we're up there and we don't actually see what's going on the ground the way we do out in the field. So I think this role is especially important. Now, the National Assessment of Epidemiologic Capacity talks about these characteristics of this state epi position, and it was formally mandated by statute or regulation in only 2 states, and it's a specific position called the state epi position in personnel system in only 19 states, and the rest of the time it's really a designated position. And is that what we are? We're a designated position. Okay. Most state EPIs, as shown here, that were surveyed, 40 out of the 50 states said that infectious disease or communicable disease surveillance was the main thing that they dealt with. And bioterrorism emergency response was a second, but the state EPIs were much less involved in these other epidemiologic disciplines, environmental health, chronic disease, occupational health, injury, etc. And if you look back at that organizational chart, we're sort of organized similarly. I'm mainly doing chronic diseases, communicable diseases right now, and we do have epi capacity, though, in chronic diseases and in environmental health and maternal child health, and the other areas. So I want to talk a little bit about the competency domains of public health practice. These are very large domains, but the reason I'm just showing this is just to show the diversity of kinds of activities that you have to have if you're actually working as an applied epidemiologist. So yes, the basic analytic and assessment capacity and basic public health science, of course you need that. But a lot of what we do is beyond that. Communication to the public, incredibly important if we're going to get our prevention messages out there. Community dimension of public health practice, getting communities involved. I think this is getting to be much more of an important issue, as especially I think with the communications that we have now. People want to know and get involved in what's happening with their health. Cultural competency. You know, as I said, I was in the HIV epidemic from the beginning. I think that really taught me very early on how important it is to be sensitive to different cultural issues and race ethnic issues, because obviously in the AIDS epidemic we really had to deal with those issues on a daily basis. Financial planning and management, these are areas that if you're at CDC, this is what you spend a lot of your time doing, is doing things like financial planning and strategic planning and management. we spend a lot of our time doing courses and other kinds of activities that are leadership systems thinking, because again, that's the lead public health agency for doing things. So I think that at CDC I certainly learned a lot about this, and I think at the local health departments again, these characteristics are very important. And then policy development and program planning, again, very important. Now, so I'm going to just say, go from there and say, no, this is what I spend my days doing. So I kind of, after Steve had given me this assignment, I sort of made categories of things that I did every day to see what I was doing. So probably at least half my time I'm actually in direct contact with the communicable disease program staff, working on various aspects of our disease surveillance, outbreak investigation, the basic things that we do. We have to work on our reporting policies. The health department is responsible for writing the rules for reporting, and so we spend some time thinking about that, and then going through the process of getting policies changed. Most recently, I think we're going to have multi-drug resistant organisms, hospital organisms, we're going to get that as a reportable disease, and so we have to go through a whole process, so we do some of that. Data security and confidentiality, this is on Jennifer's mind all the time, I think, because it's, we've had data breaches recently that I think are actually nationally famous. My EIS officer in CDC actually sent me this thing. She said, did you see this? This is Utah has really got a problem with their security of their Medicaid data. And I went, yeah, I got that. I get that. Yeah, we're famous for that. You know? So, since we hold the communicable disease surveillance databases at the health department, this is a big issue for us. We spent a lot of time liaising with the local health departments. The Epi affiliate is an organization that really is comprised of leaders of the local health departments so that we can work with them, because they're the frontline responders to the epidemics or to the communicable disease cases. So they'll do initial investigations for us, and in order for us to work as partners, we need to be in close collaboration with them. We also work closely with the laboratories and the providers who are reporting the data to us. Big part of what I do is looking at grant applications and oversight. You know, so this is a difficult time. Sequestration. I heard it on as I was driving into the city today on NPR. What the impact is on the FAA and that area, but it's really impacting us too. We last Friday, Jennifer and the rest of our managers in our group had to meet to really look at what a 5% across-the-board cut means to us. And what Bob Rawls said is sort of true, is that, you know, we have to balance our budget here. And it's very different than maybe CDC. You know, when I was up there, I don't think I ever realized how critically we are in terms of funding. And I think that after 9/11, CDC had this huge amount of money to give out to state health departments to improve the basic public health infrastructure. But after that, you know, you get this giant bolus and you start scaling back, and with sequestration that's even more severe. And so in that survey that CSTE did, really they're showing a steady decline in EPI capacity in our health departments because of the funding issues that we have to deal with. So this gets to be one of the most important areas, I think, that we spend time thinking about. Another area is systems thinking and development. I'm going to show in a minute. This is a cool health department. I was like really, really impressed with some of the things that I saw them doing, because, you know, not having been out in the field doing this kinds of things for a long time, there's a lot of innovation going on here. And then one of the areas that I personally like to work on is, now I was an associate director for science for the division of HIV/AIDS for many years, and one of my jobs there was to mentor our entire scientific staff on improving their publications and getting the quality of that up. And I think that's one of the areas that I would like to work on. I think that's a very important area. Okay, so how are we doing? Now the CSTE lists these 4 areas as essential services of public health that require epidemiologic capacity. So of course monitoring health status to identify and solve community health problems, and diagnose and investigating health problems and health hazards in the community. I think we're doing pretty good with that at the health department. I think we have capacity to do that, and we have some really outstanding young EPIs and a lot of recent graduates from here who are at the health department and can do this. And I think the last 2, and in this survey, many health departments are not doing a lot of the bottom 2. They evaluate effectiveness, accessibility, and quality of personnel or population-based health services. I call that program evaluation, basically, and research for new insights and innovations. So research, those 2 areas, program evaluation and research, I think. We do a little bit at the health department as far as I can tell, and you can correct me, Jennifer and Teresa, if I'm wrong, but I haven't seen a ton of it. I think we could do a lot more in these areas. But I think the issue is funding, because obviously research and sometimes program, but a lot of times program evaluation, you could probably do a lot of that without too much funding. But funding is an issue, and so I was talking to Steve about, there are ways that we can collaborate to help at least leverage the amount of funding that we get so that we can actually do some of these activities. I think that would be a great thing to do. Okay, so I get to show you some of the fun things that we're doing, in case you haven't been in the health department in a while. I don't know if most of you know about Trisano or UTMeds. This is the basic communicable disease surveillance software that we're using now. Now, this does so much more than just collect all the cases, okay? Because what this does is it actually is accessible at the local health department level, so you can do case contact investigations and case management and outbreak management at the local health department level, because you can access our system. It's very flexible, so you can add questionnaires to the system when you have cases that you really want to get a lot more in-depth information on. And then most recently, we're trying to get this to, we're trying to get some of our systems to talk to each other. So I'm going to tell you a little bit about our electronic laboratory reporting. It's going to come up. Okay. So Susan Motis is one of our informatics people at the health department. She's great. I really enjoy her. She gave me this slide because this is sort of the big vision for how public health reporting is eventually supposedly going to go. I hope it all works. It's quite an ambitious vision, but basically we want to see all these inputs, these laboratory reports, clinical reports, investigation data, data from various sources, hospital discharge records, medical records, birth and death records, all of this information electronically coming into the health department and populating databases in the health department for important information that we need. And that if we can do that, then we will have a system that is going to be giving you much more robust and real-time data for incidence and prevalence, trends, outbreak identification, all the things that we want to do in public health. So last Tuesday, we turned on our first lab, ARUP, the ARUP lab for electronic lab reporting. I think this is kind of cool. The lab how this works is, when people say electronic laboratory reporting, you have to get the details, or you don't really know what they're talking about, because it can mean just simply you get the electronic data into your health department, and it just comes out as a long printout, and then you sit there and get some data entry person to enter that into your system. That's not what this does. This is much beyond that. What it's actually doing is taking a paper lab result and translating that into an electronic message, and that message will come into the health department, and it actually populates that Trisano database. That's pretty intense work. We're still working out the details of this. So we have some bugs to work out, but hopefully by the end of the year, we're going to have quite a few of our labs getting our communicable disease data into the system that way. And what it also does is, since it populates that database directly, then the local health departments are automatically assigned their cases so they can actually begin their local case investigation. So it's kind of a cool system. And as it works, of course, I think it's going to be providing us with much faster, more accurate information than manual data entry. I think we were starting to look at it. It takes about, what did they say, 18 seconds to actually verify a case is a new case when you're doing electronic lab reporting, as compared to when you have to actually do the data entry the way we were doing it. Probably takes on the order of 10 to 20 minutes a case. So pretty big difference. And of course, I think the lab, as we encourage labs to do this, we're hoping that their databases themselves will get more complete as people actually are looking at the data. Another innovative thing that we're participating in is syndromic surveillance. So we have a CDC-sponsored system, BioSense 2, and this is still in the beta stage, but it's trying to look at in our urgent care departments what's going on and give us a situational awareness so that we can say, is there something going on here? Is there an outbreak that we're not detecting otherwise happening that we should be paying attention to? So this is still very new, but I think this is sort of the direction of things going, to try to get information earlier before we actually can see we know what the problem is. Okay. I love this. This is a new innovation. Have anybody tried this out here? I don't know. This is if you're not in the health department, you might not have heard about this yet, but this is another innovation that our foodborne people have come up with. So if you go on this web link, igotssick.health.utah.gov, for the next generation, they can, because I'm looking at Jennifer, she's laughing, we're not very techy people, so you can actually go on this website and report your own foodborne illness, and then ask you all the questions, and you can fill out all this information. And the little hand done figure on the right is actually a little video that talks about foodborne illnesses, and that's actually very cute. So if you haven't seen this, check it out. Go click on there. And then again, this is very closely linked to our existing databases, so we're able to this immediately populates, this information immediately populates our databases at the health department. For surveillance reports, we have our website. I think hopefully you'll start seeing higher quality reports on this website. We're going through a process right now of looking at each of our reports and trying to improve them. And especially, I think one of the areas that I would like to see more of is actual interpretation of the data to kind of guide the public as to what is really important here, what are the trends that we really think are important. I love this. IBIS is a system that you have to have access to do all of the stuff you want to do here, but you can actually, it's almost like you can actually, for a while this wasn't very up to date. It was kind of, hit and miss, but one of our EPIs, Mindy Names, has really worked on getting this up to date and really enhanced a lot of the features of IBIS, especially for the people who have access to the data querying capacities. But we also have these indicator reports, so you can go on there and for most of the diseases get the latest trends of the data that we have. Of course, we do some outbreak investigations. This year, as I look back and talk to our EPIs, these are the areas that we've done outbreak investigations in. And so I think we do have that capacity, and we are conducting quite a few of these. This is an area that the state EPI position, I think, is very different from what we have to do in at the federal level. And this is to respond to local legislative mandates. So when the legislature is in session, we have to keep an eye constantly, and Teresa tells us what's going on all the time, and Bob Rolfs also comes down and tells us what's going on, because we have to fulfill these mandates that come down to us. So an example is one of them is House Bill 55, which was passed last year, and it was mandated that the department publish a facility-specific report on incidents of nosocomial infections by facility. So obviously you can see what the possibility for creating some political issues that would, because basically you can, a consumer can go onto that report and say, well, this hospital has a lot more infections than that hospital, so maybe I should pick that one. But hopefully we have some good leadership at the Health Department in Sherry Varley and Louise Eutropius, who have really worked out well with the governance committee of hospital infections and here and smooth this mandate out. So that I think we're going to get a report that will be acceptable to everyone. Another example is that now this legislature has requested us to look at the feasibility of funding sources for Parkinson's disease registry. So I didn't know that I'd ever be looking at something like that, but I may be doing that shortly here. And then we have to also, in the role of state epidemiologists, we have to look at responses to public concerns. So this year, one of the biggest areas of concern, of course, was our horrible air quality issue. So Jennifer and Sam Lefevre, who is our environmental lead EPI, put together a working group that would look at, with the other agencies, Division of Air Quality and some community people, to really try to figure out what we should do about our air quality and what we should put up on our website as advice to consumers, etc. So that kind of activity is pretty common. We have to respond to what the public concerns are. And then another area is this networking across our agencies to be prepared for emergency response. Now, if I think about what keeps me awake at night, like Jennifer was telling me, well, she wakes up at night and was startled by something. Well, what wakes me up at night is, what if we have the giant earthquake? Are we prepared for the response to this? And I think that's something that I think I really want to learn about in the next few months. Is a lot more about how prepared are we, because I think this is certainly an area that we will be called on the spot for if it ever happens. And then finally, some other roles for the state EPI. I volunteer on the IRB, which has been an interesting experience. And I also hope I can continue to mentor our young staff epidemiologists EIS. We have Joanne here as our EIS officer. We have a CSTE fellow, and then we have many student interns that rotate through our health department, and we hope that we'll be able to continue that. And then again, I think the program evaluation and research is the two areas that I think I would like to see us do a little bit more of, but again, obviously funding dependent, but hopefully while I'm here we can work on doing a little bit more of those things. So, role of the state epidemiologist in Utah in 2013. It's the jack of all trades, basically. It's what I told you in this presentation. We do a lot of things. I am very glad to be in this role. I think that my background is a federal perspective, but I think that since I have done so many different kinds of things at CDC, I think I feel sort of well prepared to do a lot of these things. Now, I think it's premature to give a vision and goal statement, but I thought I'd take a crack at it. So this is what I think of that as personal goals for me to think about in the next 10 to 20 years for Utah. I think it's going to be really important for us to improve our cost-effective linkages between our healthcare systems and public health. I think that, of course, the healthcare cost crisis is probably one of the most important issues that we're going to have to deal with. And I think public health should be at the table there and really participate in that. I think we need to focus our efforts on what matters most. So I look around at the healthy population we have in Utah, but we should be spending more time on issues like obesity, emergency preparedness, emerging infectious disease, because those are probably the things that are most important. And so maybe as I go on, I'd like to focus my interest more in those areas. I think we have to be a constantly learning agency to make ourselves prepared for the future. You know, science in so many ways is advancing so quickly. You know, one of the things about this position is the generalist position, right? So you learn about all kinds of new things. That's actually one of the reasons I like it. But, you know, every time I get to talk to somebody who's a specialist in one of these areas at CDC, so that's what we did at this orientation, they tell me such amazing things like, well, we're going to pretty soon get rid of all our culture capacity for labs because we're going to do everything by molecular whatever. And I go, really? Is that how things are really going? And so I think that we have to have an environment where we're constantly learning about these new technologies that are occurring and applying them to public health. I think we're doing that pretty well in some of our areas, informatics, but we could modernize in some other areas. I think investing in our future. This is really important because obviously all of us aren't going to be around, but we really need to continue to support our young people to pursue careers in applied epidemiology. And finally, I think the last is we need to find better ways of communicating, maybe using some of the newer tools that people, you know, people get information different ways than we did in my generation, really. But we need to communicate our public health messages to the public in a way that they can really consume it and incorporate public health interventions into their lives. And I think that's the finally important priority. Okay, so if I do a decent job, I mean, this is what somebody, if I don't do a good job, I'm sure Jennifer and Teresa will let me know. And thank you very much. This is my friend in Africa who is very happy that you listened to me. Thank you.